So now I'd like to introduce Dr. Lauralyn McIntyre, who will tell us about her cutting-edge work in the field of septic shock using stem cells. And she has a clinical trial that's right now underway. She's treating people right now. So.
Oh, thanks so much for that kind introduction. I don't have any slides for today. I'm just going to chat briefly to you and with you. Hopefully we can get a discussion going. So it's so nice to be here. It's so inspiring to listen to these other folk talk. It inspires me to want to do more. And it's so nice to have the opportunity to speak with the public about the research that we do, because it's not very often that happens. So thanks for the opportunity. So as Dr. Sorenberger was saying, I do quite a bit of research in the intensive care unit, so for critically ill patients, and my focus over the last several years has been to study patients that have the most severe form of infection that we see in the ICU, which is called septic shock. And about 5 years ago, Dr. Duncan Stewart, who is the CEO of the OHRI, so a very prolific researcher and just certainly a really, really down-to-earth, good human being, approached me and said, "Hey, Lauralyn, what do you think about studying mesenchymal stem cells in the setting of septic shock?" And then he went on and he told me about some seminal work that himself and a whole bunch of other folk that work with him had done in mouse models to suggest that maybe these stem cells may be effective for treating septic shock. And that's where this all started, really, 5 years ago. And since then, we call this a program of research, because to be honest, there are a number of different studies that we've done as a team that have really worked towards building towards this very small phase 1, sort of first in human clinical trial in septic shock. And so I'm working with many people within the OHRI, but also nationally through a national group of critical care investigators that do clinical trial work as well as translational work. So the translational biology group, the Canadian Critical Care Translational Biology Group, and the Canadian Critical Care Trials Group have all been involved really since the inception of this idea, started about 5 years ago. So you might say, well, what the heck is really septic shock? So, I mean, septic shock is truly the most severe form of infection that we see for patients that are admitted to hospital. If you don't treat somebody with septic shock, they will die. It's not something that you can turn around just with an aspirin or for the Tylenol. It is a very, very severe form of infection. And the mortality rate associated with this problem ranges anywhere from 20 to upwards to 50%, with the more severe forms of this problem also being associated with the failure of your different organs. So your brain fails, your heart fails, your blood vessels fail, your kidneys fail, and your lungs can fail. So pretty much every organ system can go down in this problem. So they fail acutely, and then if we get to the point where you can survive from this problem, it goes on from there, because the other thing that happens with this devastating issue is that you're left weak, you're left extremely weak from it. And so even if you survive your intensive care unit stay and then you go out to the hospital ward, it's often weeks, if not months, before we can get you back home, if you're able to get back home. And we know that even several years out from this problem that there are issues with ongoing weakness, that people have just not been able to get back to so their baseline functional status. In addition, there are psychological issues that happen with being that sick, post-traumatic stress, depression, it goes on and on. So it's an immense problem. Although it represents 2 to 3% of hospital admissions, it is the most common reason why patients get admitted to a medical surgical intensive care unit. And the frustrating thing about it is that although we're better at identifying and giving fluids early and getting antibiotics to kill the bugs that cause the problem early, we're still left with this mortality rate and organ failure rate, and even for survivors, that long-term morbidity that's associated with this. So we still have a lot of work to do. And there are decades of research that have been done looking for different, like, golden bullets to treat this problem, different immune modulatory therapies, and none of them, not one of them, unfortunately, have demonstrated a positive effect. So it's not all doom and gloom, because we have made some inroads with regard to the treatment of this problem through just early identification and resuscitating them and giving them antibiotics and getting them to the ICU sooner and faster, but we still have work to do. And so that's where this stem cell idea comes in. So the stem cell idea is these are mesenchymal stem cells, not embryonic stem cells, or not those hematopoietic stem cells that were talked about just before. But these are early cells that are found in many different tissues of the body. The ones that are probably the most well described are the ones from the bone marrow. But they're found in the cord, and they're found in the fat, and they're found in in periodontal tissue. They're found throughout the body. And these types of stem cells can differentiate, but they don't differentiate into any type of organ or any kind of tissue. There's limited numbers of tissues that they can differentiate into, and they are identified through different cell surface receptors, either being positive or being negative. And so the cells that we plan to use within the phase 1 clinical trial that we're running are cells that we actually derive from healthy bone marrow from volunteers here in Ottawa. So people in Ottawa have altruistically donated their marrow to be part of this clinical trial, which to me is just beautiful in and of itself. But in the development of getting to actually conducting this phase 1 clinical trial, our team needed to do a whole lot of background work. So in addition to the seminal work that Dr. Stewart and his lab and colleagues conducted to sort of get the fire going, we went ahead and we did a systematic search of all the preclinical studies. So all the mouse and rat and rabbits and whatever animal studies that have been done looking at the use of these cells in animal models in sepsis to see, do they really work? Because one of the challenges we have is although we're proud of the work that has been done with our team, we wanted to be not biased and say, hey, well, what's the totality of all the evidence that's out there? Is it just us, or has this been replicated elsewhere? And how much confidence do we have in our ability to say, yep, these cells work? And do they reduce organ failure? Do they reduce death in animal models, and so on and so on? So we've just updated once again. We call this a systematic review of the literature to look at all of the animal studies that have looked at stem cells for the treatment of experimental sepsis. And just repeatedly, the studies demonstrate that death is reduced, that they modulate the immune system that was talked about earlier, that because septic shock, especially in its early stages, is associated with this profound inflammatory state that's both pro-inflammatory and anti-inflammatory. And these cells modulate genes associated with the immune system, over 3,000 of them, in fact. But you may be thinking, well, you just told me that there are a whole bunch of immune modulatory therapies in the past and none of them have worked. So what's different about these stem cells, because it's just another immune modulatory therapy? Well, the neat thing about the cells is not only do they immune modulate, but they seem to help with repair of tissues as well. So we know that in septic shock you get really, really leaky. Your blood vessels get very leaky. When you give fluids, you just turn into a pincushion within the first 24 hours, if you've seen somebody with this problem, because we give liters and liters of fluid. And the cells seem to, in animal models, restore the integrity of your blood vessels, so they leak less. In addition to that, the animal models have suggested that these measures of organ dysfunction are also improved. And finally, another really unique property, or two unique properties, is that they seem to clear pathogens better. They seem to clear the bugs better than if you just use regular treatments. And so that is particularly interesting in this problem, because this problem is associated with the most severe form of infection. And then finally, we know that in septic shock there are issues with energy, with how the cells use and how active the cells are with their energy and how they use energy in septic shock. And there are some data to suggest that maybe the cells in this context may actually restore homeostasis with respect to energy as well. So with all of that, we said, okay, we think we've got sufficient biologic rationale and preclinical evidence to go forward to a clinical trial. But as I was saying, septic shock is a huge problem associated with loads and loads of adverse events just because of the problem, just because of the severity of the illness. So we said, okay, we need to see if these cells are safe in clinical trials. But we knew they hadn't been done in any critically ill patient at the time when we were designing this. So our team went back and said, okay, well, let's just look at the safety of these cells being used in different clinical trials. Randomized, so these are randomized control trials. You flip a coin and half the patients get the cells and half the patients get control. So you actually have a control group to compare against, especially when you're looking at adverse events. That's really important. What's the baseline event risk? And so we did a systematic review looking at that, and that's also been updated over the last couple of years. And now we started with 8 randomized control trials, and now we're up to 24 randomized control trials. So they're all very, very small, that have been done in heterogeneous patient population, like some in heart failure, some in cardiac population, some in autoimmune diseases. But I can tell you that there haven't been any serious adverse safety signals within the context of our systematic review. So, other than the generation of fever that seemed to be self-limited within these studies. So that gave us more impetus to say, okay, well, we think that we're safe even in humans, and so then we went ahead and we designed the phase 1 clinical trial, and that took a few years to be honest, to get designed. And went through the Research Ethics Board, and it's been through Health Canada, and they all approved it, and so we've been conducting the trial over the last I think 10 months now, and we have 6 patients in, and we are almost done. We have 3 more patients to recruit. This is what we call a phase 1 dose escalation study, where we start with a low dose, give it to 3 patients, make sure it's tolerable, and we have an independent review board that says, yep, you're being safe, there's no excess adverse events that we can see here, move forward to the next dose. So we've done the first dose, the second dose, and we've just got approval from our independent safety board to move to the high dose. So 3 more patients. That's just the initial phase, and we're very excited because the cells have been very well tolerated thus far, and certainly no adverse events that are thought to be related to the cells. And it's given our team a lot of impetus for moving forward to doing the next study, which is going to be that randomized trial where you flip a coin and you give 50% of the patients the cells and 50% the control, and then we go forward and we'll have enough patients to actually start understanding if there's any evidence that the cells are efficacious or helpful in this setting. Do they reduce organ failure, for example? Do they reduce how much time you spend in the intensive care unit, that kind of thing? And that's what we would call a phase 2 multi-center randomized control trial. And we hope that we may even be ready to start recruiting into that trial by the end of this year, if everything continues to go as planned. But it's not without the team and the community. This is not a one-person show. This is very much a team, and I'm blessed to have a team. Thanks for the opportunity to talk to you.
Can I have more details about the role that auto donors have played in? You were saying that just volunteer donors have given stem cells. That's outward separately from the stem cell banks that we have, right?
Yeah,
is that true?
The donors are anonymous,
Yep.
and this is we did collaborate though with Canadian Blood Services, and the one match through David Allen actually gave us a whole lot of help because, as I was saying, there's so many different studies that were done as an offshoot just to getting us to the phase 1 trial, and one of it was just developing a bone marrow protocol and developing a protocol such that we identified the right people that could donate their cells so that it was safe, they were healthy, and so on and so forth. So yeah, they are auto ones that have donated their cells.
Do the donors need to be matched, or are they?
No. So the neat thing about this, the trial, is that the cells are felt to be almost ghost-like when they enter the system because they lack the cell surface recognition receptors. And in the clinical trials to date that we've also examined, the randomized controlled trials, looking for any potential immune rejection between one arm versus the other, we just haven't seen any of that. So these are what we call allogeneic cells. So autologous cells are your own cells. Allogeneic cells are cells that somebody else has given to donate, and that is what this trial's about. And you might say, well, why wouldn't you just use autologous cells? Wouldn't they be the cleanest and the most similar to the patient? Well, the patients are very, very sick, for one. You don't know how the bone marrow would be reacting in that situation because, as I said, every system in septic shock goes down. But as if, and not even more importantly, septic shock is not a problem that you can treat within, months or years. Septic shock is a problem that you need to treat within minutes of identification and then hours. So the cells are within the trial, or as part of our inclusion criteria, are actually administered within 24 hours of admission to the intensive care unit.
Why do you use the mesenchymal cells and not like the other ones that were discussed earlier?
Well, these hematopoietic stem, those stem cells develop into blood cells.
Oh,
So that's what their mandate is, whereas these cells actually have these properties where they can modulate, and they modulate the immune system, and we think their main mechanism of action is not through implantation and growth, but through cross-talking with other cells, and through their, what we call the paracrine effects.
If people come in with the septic shock and you say you need to treat them very quickly, how do you get their permission, sort of ethically,
Oh, yes.
to sign up to
That's an excellent question, and it's a question that we deal with not just with this trial, but for every single critical care trial that you do, because you're absolutely right. We know data from trials that we've done in the IC that 90% of the consent procedures occur with surrogate decision makers or with the family. You have to, otherwise you can't recruit patients. Yeah.
And what's the degree of awareness of the emergency doctors to get a patient that comes with a septic shock?
Septic shock is tough. It's a sneaky, frustrating problem. And we train, because it's not like somebody's having like massive chest pain and their ECG is abnormal and they're having an MI and it's a single system problem. They can present with just a little bit of fever and maybe they're just a tiny bit short of breath, but they're not really that short of breath. And maybe their oxygen's to saturation to just a little bit low, but not profoundly low. So you're right, or not, I shouldn't say you're right, but I think I know what you're getting at. It's like, well, how do you get these patients identified? It's a lot of training, it's a lot of awareness. And I think that because there are some research now that suggests that the earlier we get the patients identified, the faster we get them resuscitated, the earlier we get the antibiotics and they do better, there's a lot more awareness and there's a lot more impetus and to actually make sure that we identify these patients properly, early. But it isn't always that straightforward. It's just not.
Is there buy-in in the community for this, for these therapies?
I think we have to define what we mean by community.
Okay.
Certainly with my research community, it's crazy buy-in. People are so excited about this, but we're tempered with our excitement because of all the failures that we've seen in the past with the clinical trial. So we have to, and we're determined as a research community to try and design the trial in such a rigorous, methodical, rigorous format, not going too fast just to be like number one, but to actually do it right. That is the key so that we can answer the question for our patients. But in terms of the larger community, this is my first or second actually opportunity to give more of a public forum and to talk to you about this. And I think we, as researchers, I think we need to do more of it because it's you guys that make it, and it's all of you that we're treating, and so we need to do this together. In my opinion. Thank you.
So some patients did receive the stem cells?
Yes.
And how are they?
Well, we've, as I was saying, that the stem cells themselves have been very well tolerated. So in this early phase clinical trial, one of the main things we're doing are assessing our adverse events and how well tolerated are the cells. And when we designed the trial, we had specific criteria to say, okay, well, if these things don't happen, the cells are very, very well tolerated. And so by all the criteria that we predefined in the clinical trial, with every single patient that's been recruited has tolerated them very well.
So that means that they've gone better? They're feeling like the septic shock?
Yeah, the patients have done well, but I really I strongly caution too much early excitement about saying whether they're better or not, or they are better. And some of my colleagues have said, whoa, they're remarkably better. But to be honest, it may just be because our senses are heightened to the fact that we know these patients have received an experimental treatment. So we want to be excited and we're very determined to go forward, but we just temper it because we need that control group. We really need the control group for the phase 2 trial. And that's why when we were talking earlier about, stem cell tourism or just giving the cells, why shouldn't you just give it to me? Well, we still need to evaluate safety. We need to evaluate efficacy. We need to know. And there's a cost to giving this to us and to our economy. So we need to make sure that we're working before we roll this out. So
Hi.
give the stem cells to patients?
Oh, it's just through an intravenous line.
Oh,
Yeah, it's really pretty straightforward, actually. Yeah, I mean, the stem, you know, the manufacturing facilities in the US, they might not say that because they go through this amazing, really. So, and I haven't mentioned this because this, and they really need to be mentioned because the folk that are manufacturing and growing out the stem cells, that's a whole separate program of research. We work together, but it's mind-boggling all the rigor that they need to have in order to grow the cells and have them appropriately ready for delivery into a patient. But they're a huge, huge part of our team. Yeah.
Which is just further indication that one of the key takeaways here is this is highly experimental stuff, but the future is now. Stem cell therapies are being tested now. This is in the clinic now. This is not something that's going to be 10 years from now, 20 years from now. This is work that's being done now. And it's not just in this area. Fantastic work being done in MS. There's fantastic work being done in diabetes. Here in Canada, there's only a program that insulin was discovered here. This is an area where Canada really is doing world-leading work, and this is part of it. And so thank you very much for it's a fascinating trial, and we look forward to reading about the results. So.